FRêMITO, o podcast vascular do perfil O Fogart da Madrugada.
Esse é o FRêMITO Podcast Vascular, direto do Congresso Science 2024, e nós estamos recebendo aqui o Dr. Nicola Tusin, que é o chefe da cadeira de cirurgia vascular da cidade de Reggio Emilia, na Itália, e ele vai discutir com a gente algumas soluções práticas para o tratamento do aneurisma abdominal de colo curto. So, Dr. Nicola, we are very welcome to have you here. Thank you very much.
Thank you very much. I'm happy to be here.
So we know that you discuss here in the Congress some tips and tricks to treat AAA with a short neck. So talk a little bit about it for us, please.
Yes, short neck or style neck are a big problem, so-called justa-renal aneurysm, because during the endovascular treatment of this type of AAA, the risk of 1A endoleak is very high. So one option for a patient not suitable for traditional surgery with over-renal clamping, so very aggressive. So for older people, polypathology people, the second option is the endovascular treatment. Endovascular treatment has some problem because you have to use, in the first part of our experience in the past, we use a lot of chimney technique with excluder graft with parallel chimney. But the problem of the gutter, is provide often 1A endoleak. So is a patient that we use only in emergency. The second option is the beaver endograft, especially endobranch if you have a short, very little neck. But this type of procedure are very complicated. You need the cannulation
very time consuming.
Yes, time consuming, contrast medium consuming, a long time of anesthesia.
Expensive.
If you have patient very fragile, you can't permit so great operation. So we have now arrived to a new concept of device that is the Braille produce endograft custom made. That is a graft with a neck of the graft with the three fenestration 360 degrees for the renal artery, for the superior mesenteric artery, for the celiac trunk. What is the sense of this so-called castle? Is the provide a columnar efficacy force to maintain the graft on the neck, because under the renal artery there is a conical part of the graft with a triple stent, peak to valley, very quick, very short, that provide a force on the conical part of the aneurysm because the neck is very short. So provide the sealing. You have no neck, you gain the sealing in the conical part of the neck, in the justa-renal artery. After all, there is the main body, there is a bowel. So the main body is not cylindrical, but is a bowel in the center of the main body, about 50 millimeters. But it's custom made if you can. You can also show little minor, and it provides to the occlusion of the lumbar artery and inferior mesenteric artery. So provide to the occlusion to the endoleak type 2. That is the big problem of.
So you even prevent the endoleak type 2.
Yes.
It.
Sometimes when we perform, for example, normal EVAR with a big aneurysm without so much thrombus. We have a big inferior mesenteric artery, a big lumbar. So enter and you are sure that you have endoleak.
Sure.
And so sometimes we perform embolization in the first step of the inferior mesenteric artery, also on the lumbar, and the second time we deploy the EVAR.
In the same procedure, or
in 2 steps.
Okay.
2 steps.
It's a very smart way to treat.
You must have like a minimum length of
neck to use this technique?
Yes, you need about 2-5 millimeters but the conical part of the graft is very useful because the position of this type of stent, triple stent, peak to valley, apply a force on the conical part and the endoleak type 1, we don't have endoleak type 1 in the first series of cases.
How many did you perform already? How many cases?
7 cases abdominal and 1 thoracic.
Oh, okay.
And how is going the results?
The results are very good because the patient was very fragile, and so I noted we work always in the hybrid room. We have a good machine, so we can work with the marker for the visceral artery. We have from 2017. We used this type of device, the angiographic robotized from GE, the Discovery 740, that provide to us the position of the visceral artery, so we can work quickly without contrast medium, checking also sometimes only one check for the visceral, for the renal artery.
2
because
injections and that's
we
it.
use the fusion, fusion the rendering. We check at the time of the opening of the graft, we check if the matching from the rendering and virtual reconstruction and marker are real. Because always the possibility that you can move the patient or the patient move the belly, and so you have the risk. You have to check one time.
So sometimes do you use IVUS for it?
Yes, we use mainly if we have to do sometime. In this case, we use or in dissection, thoracic dissection, in thoracic aneurysm, to check and control the left subclavian artery, because it's very dangerous sometimes the subclavian artery, the left, because can be posterior. And so with the IVUS, you can put the IVUS in the ostium, and when you open the graft, you know very well in reality what is in your screen you saw where is the ostium. So IVUS is very effective.
In all those cases of the fenestration you used, you did the custom-made device with the Brazilian company Braille or other companies?
No, we use nowadays we start working with Cook, obviously, because it was the first, but after we use now we use mainly Geotech Artivion, especially inside. We perform a lot, 15 in the last year, 15 cases of inside, cases of thoracoabdominal complete from the isthmic, some cases from the isthmic aortic artery to the bifurcation of the iliac artery with inside and thoracic TIVAR.
And
in
there's
2 steps.
Any of these cases that you need to come back and redo the procedure or complete or something else?
Oh, now we have sometimes endoleak type 2, for example. 2. Yes.
So better.
Yes, better, because we can, when you have 19 aneurysm of thoracic artery and 80 of the abdominal artery, endoleak type 2 is not a big problem. You can provide. We have a big volume center of endograft and endovascular treatment, so we can provide to the embolization of the lumbar, of the mesenteric through the superior arcata riolano, and from iliaco-lumbar with a microcatheter we can embolize. So we do everything by ourselves, without the radiologist, without anybody. We have all the material. We do everything by ourselves.
Amazing.
Nice.
Thank you, Dr. Nicola, to share with us your knowledge.
Thank you to us.
We hope that you enjoy in Brazil.
Thank you.
Não deixe de acompanhar e curtir os episódios do FRêMITO Podcast Vascular, direto do Congresso Science 2024.
FRêMITO, o podcast vascular do perfil O Fogart da Madrugada.